Hi, and welcome to my presentation on ACE inhibitors and protecting the kidney. I'd first like to say that this is a presentation that's geared more towards clinicians, so healthcare professionals and students learning about these things. This is a little bit complicated in terms of the anatomy and physiology and some of the drug classes and that kind of thing that I'm talking about. However, if you happen to not be in a healthcare field and are just interested in this, I think you'll get something from it, something valuable, and I also think if you had any questions you'd like to post in the comments, I should be able to help you quite a bit in kind of alleviating any confusion or helping you with that. So the reason why the title is in the form of a question is because, and I just want to give you the impetus for producing this presentation, and that's because when I was a student a very long time ago, I was told at some point that ACE inhibitors are very good for the kidneys, okay, especially if someone has hypertension or high blood pressure. You want to lower the pressure, and that's what these drugs do. And that made perfect sense. And then at a different time, don't recall if it was a different professor, but I know it was a different lecture, we had learned that ACE inhibitors could be detrimental to kidney function. And to be honest with you, I never really learned the exact mechanism behind that, or in what situations those are true until becoming a professor, honestly. So what I wanted to do is demystify that. Since I've demystified it for myself, hopefully I can help other people by demystifying it here. So it turns out that it's context dependent. So it depends on the cause of the hypertension. And without further ado, I'm going to proceed and show you exactly what I'm talking about over the next few slides here. So I wanted to start off, before I get back into the drug class, the RAAS inhibitors, and before I get into hypertension, I wanted to talk about a specific pathology that is central to this whole idea of whether or not you should use a RAAS inhibitor, and that's called renal artery stenosis. And what I'm going to show here is a simple animation, and that's opening up one of the renal arteries. And by the way, the anatomy here is that this is the abdominal aorta, and it's very simplified anatomy. We're missing some vessels and things, but just to emphasize that the kidneys are basically fed very thoroughly from the main blood supply coming from the heart, which is the aorta here, with the renal arteries. So I'm going to basically cut one open and show you what it would be like in a little bit of a safer situation, and then what happens if there's narrowing or buildup of atherosclerosis. So right now I'm showing just a little bit of atherosclerotic buildup, so things like LDL stuck under the endothelium or under the blood vessel wall there. And then I'm showing some red blood cells. So I'm going to use red blood cells to illustrate blood flow. Of course, this is also filled with plasma, so the fluid there. So you could see in this situation where there's only a little bit of buildup, blood flows fairly well. Okay, so we don't have renal artery stenosis yet in this case. Now you see here that there's more plaque buildup. This is called renal artery stenosis. Not that the blood vessel is getting smaller or getting constricted, it's that there is a narrowing inside the wall because of buildup of cholesterol, or it's more complicated than that. It's atherosclerotic plaque, which has a lot more components to it, which we won't get into now. So showing the blood cells having some trouble getting through, okay? So they're having some trouble getting through. And by the way, stenosis is narrowing, and this is easily confused at times with sclerosis, which is hardening. Those are not mutually exclusive, so they can happen together. But the fundamental problem here is the stenosis or narrowing. Okay, notice, so the red blood cells can't get through. So imagine then fluid has some trouble getting through as well. Okay, so what does renal artery stenosis mean for renal blood flow and glomerular pressure? So if you're not familiar with what a glomerulus is, we'll get into that in a little bit, but there's about 1 million in each kidney, and that's what does most of the really all the filtration. Okay, so imagine then if this happened, you have stenosis or stenotic artery, you have low blood flow. That would mean, I always use the analogy of like a garden hose. If you restrict flow, you're going to have lower pressure after the restriction point. Okay, or any plumbing system is basically what this is similar to. So we have low pressure afterwards, Okay, so what does that mean? That means not only low pressure in the major vessel, but then everything after that has lower pressure. That would be all the different arteries and arterioles, okay, even capillaries. So that means low glomerular pressure and then poor filtration. Okay, so if a patient without any medications, if they already have renal artery stenosis, they're going to start having trouble filtering the blood, which means they're going to have fluid overload, and a lot of other things will be overloaded because they won't be eliminated. So the question I wanted to pose, because this is often, I would say, from my experience, it's often a misconception. Does poor filtration due to low pressure equal kidney damage? Meaning, if you're just not getting enough blood flow to the kidney, particularly enough pressure in the glomeruli where the filtration occurs, is that kidney damage? Well, the answer is absolutely not. And hopefully, most of you can quickly come to the conclusion that that's not really damage in the rationale behind it. And the reason for that is that just because you're not putting a lot of pressure in the glomerulus, it doesn't damage the glomerulus, right? You're not harming it. You're just not letting it filter well. Okay, so some of the misconceptions we see is that if you look in the blood labs, and you see things starting to elevate, things that are supposed to be filtered are starting to elevate, like creatinine, you might say there's renal damage. Well, that's a big mistake to call it damage without knowing for sure, because it could be just poor filtration. Um, However, and we'll get into this in a second here, but hypertension, yeah, that can cause kidney damage. If though we have this unique situation where we have renal artery stenosis and the blood pressure is low after the blockage, but still elevated before the blockage, we will still have hypertension. In fact, that would be the cause of the hypertension, but we would have low pressure afterwards. So the question I want to pose now is, what happens if we further reduce glomerular pressure by a different mechanism? So I'm telling you it's already low here, and that it's low going in all the way into the micro vessels. What if we lower it even more? And what I'm getting at is what if we use a medication in the RAAS inhibitor class to do that? So we're gonna cover that in just a second, but right now I'm showing you what the whole kidney is going to look like, and then if we kind of cut away some, just going over the basic anatomy. These are the renal pyramids. Okay, these this is the blood supply. So we're starting all the way from the renal artery. We have all different types or different names of arteries, which I won't get into here. But as we go further and further, it gets smaller and smaller. And finally, it goes in, this blood feeds into one of these things called nephrons, and there's about 1 million in each kidney. And this is where the real important function happens, the magic there, which is the filtration. So zooming in on this, just to show you exactly what's happening. So blood is flowing in, and red is, by convention, red is going to be an artery, okay? And that is going through this bundle of capillaries called the glomerulus. This entire structure is the nephron. So when fluid is filtered here, it will go in throughout the whole nephron. It'll travel, and a lot of things will happen to it. Throughout that pathway, things will happen. Fluid will be removed or reabsorbed. Electrolytes will be, in or out. pH will change. There's a lot of things happening, but we're not going to get into too much detail there in this presentation. But ultimately, in the end, it goes into something called the collecting tubule and then the collecting duct, where multiple nephrons will be draining in, which I have cut off here, and that'll go finally into basically the papilla, and then into one of the ureters. So this is just to give you the idea of from start to finish, what is the flow of fluid, okay, and what are the major players in that, okay, and yes, all these are surrounded by capillaries. Okay, every nephron, again, this is only just an example of one of them, but every one of those nephrons will be surrounded by capillaries, arteries, and veins. Okay, so that's called the vasa recta. So what we're going to do now is kind of start getting into more of the detail here. So we've zoomed in on the nephron, and what I'm going to do now is transition to a much more detailed model of the nephron, where we can start talking about the glomerulus in more detail, and the afferent and efferent arterioles. So this is my more detailed model of part of the nephron. Okay, so just going over the basic anatomy. This is going to be considered the glomerulus. What's going into it is called the afferent. Some people might say afferent to make it more clear, but that's the afferent arteriole going in. There's the bundle of capillaries, which is the glomerulus, and then there's the efferent arteriole, which is leaving. Okay, so remember there's about 1 million in each kidney of this nephron, and this is where all the filtration is happening. Okay, so this bundle of capillaries is absolutely critical, and it has to have the right pressure, and not, we don't want any scar tissue and things like that. We essentially want just the appropriate amount of pressure to filter. If there's too much pressure, there could be damage there. If there's too little pressure, we won't have very adequate filtration. Okay, and this is, by the way, the proximal tubule, which is where the urine will first travel, which is actually called the ultrafiltrate before it becomes real urine. It's just starting to form, and that's the ultrafiltrate, which will travel after filtration through the glomerulus. I'm not going to get into much on the macula densa today, but the macula densa has a major role in sensing sodium and chloride and determining whether or not we're going to retain fluid through communication with the afferent arteriole. But we're not going to do that too much right now because the focus is on the direct effect of the medications. So we zoomed in on the whole structure. Okay, now I'm going to start getting into the two different scenarios. Actually, there's four, but one case is going to be hypertension without renal artery stenosis. Then we're going to have hypertension because of renal artery stenosis. But in both of those cases, we're also going to talk about what the RAAS inhibitors would do. So kind of in a sense, four scenarios. Okay, so what you see here is, so I'm adding a little bit of detail because any expert in this field would have already noticed that we're missing a major important structure here, and that would be the podocytes, okay, which I'm going to show you in a second. But these glomerular capillaries are not standalone, they're not solo. They're going to be surrounded by cells, epithelial cells called podocytes, and they also have these pores in them. And I'm only showing that on a portion to simplify it. But throughout the whole bundle of capillaries would be these pores called fenestrations, okay, and which are a little different from other capillaries. They're kind of intermediate in terms of their porosity. So this is relatively non-selective, in terms of what will get filtered through. The only things that will not get filtered through are the larger things like plasma proteins. Anything smaller than that will typically get filtered through. So again, the next player in the game here will be the podocytes. Podocytes are named that way because they have basically these foot processes called pedicels. They interdigitate would be the term that would be used, and that means it's like when you put your fingers together in between each other. Okay, so that's what's happening here. That, without podocytes, we don't have control over our glomerular filtration. Okay, so these little slits in between these finger-like projections, those slits are tightly regulated and they have very specific proteins, which would be called the slit diaphragm, that would be made up by those proteins to allow filtration and to control the size of the molecules and substances that are filtered. If we interfered with the podocytes, if we damaged them, and they lost their pedicels here, and there's a gap, we have gaps that form, then we start to have a problem, okay, with filtration being non-selective. So we're on the situation now where, again, we have hypertension without renal artery stenosis. So that leads to excess pressure in the arterioles and glomerular capillaries. So I'm showing you that the standard case where someone just has high blood pressure, it's not going to damage their kidneys in a day or in a week. It's going to be a gradual impact on kidney function. But yes, hypertension causes target organ damage, and one of the target organs is the kidney. Okay. So in this case, when there's hypertension, the fenestrations, which are here in the filtration slits, will expand too much. And the term that's often used, and it's been used for many decades, is protein spilling will occur, and that will go right into the tubule. So this right here is just showing you that we've gotten, just to emphasize that, to exaggerate it, too much pressure building up. We've opened up the filtration slits. We're losing our size selectivity, and again, These would be throughout the whole glomerulus, but I've simplified it by just adding the podocytes in one region here. But these slits are expanding, and that's going to be a problem. Okay, so I'm just showing you what's happening with filtration. Filtration will, so that was supposed to be serum or plasma going through. The filtration will occur, okay? And let me clarify, it's not really just pure plasma. Like I said, because we lost the plasma protein, that didn't go through, that stayed in the blood. So what got filtered was the fluid and smaller substances. Okay, so that was to represent that filtration is occurring. And that's good that we have filtration, but the problem is we also have albumin filtration. That should not happen, or albumin movement into the urine. Okay, and then what we see is, right, the old-fashioned dipstick would show proteinuria. Microalbuminuria is when there's less, or just overt proteinuria when there's more. That's a very clear indicator of glomerular excess pressure and probably glomerular damage. When we use a RAAS inhibitor, such as ACE inhibitors, they dilate the renal arterioles, primarily the efferent arteriole to a greater extent. Okay, so if we do that, that's considered renoprotective. If we dilate here in the efferent arteriole, we reduce the pressure in the glomerulus by allowing more blood to flow out, and then we prevent excess stretching of the filtration slits here in the fenestrations. So see, we dilated here, just exaggerating that. That allowed us to shrink down our glomerular vessel, glomerular capillaries, and that gave us, or put us back in a normal situation where we're good and we're not spilling protein into the urine there. So I flipped the page. Now we have the other scenario where there's renal artery stenosis as the cause of hypertension. So again, that's that interesting situation where the majority of your circulatory system is hypertensive, but that's because you have a blockage going to your kidneys. So after that blockage, the pressure is too low. Okay, so you have whole body hypertension, but renal hypotension or low pressure. And that means you have poor filtration and plasma fluid excess. So you build up a lot of fluid in your circulatory system and electrolytes and things like that. So to kind of emphasize that, I have this flow slowing down a little bit, slowing down because you have a narrowing of the renal artery. And I'm showing you have kind of poor filtration because there's not enough pressure in the glomerulus. The glomerular filtration is almost strictly determined by the pressure in the blood, in the capillaries, and then the pressure in what we call here the Bowman's capsule. Okay, the difference between those pressures determines the flow rate of the fluid through those pores. So if we add a RAAS inhibitor, now imagine we have a situation where we already have low pressure because renal artery stenosis, right? So we don't have much fluid coming up here into the capillaries. So imagine we add a drug that dilates the outlet port or the efferent arteriole. That actually lowers the pressure even more and causes even more poor filtration, where it's going to basically, the glomerulus in that case will almost serve no function. So not really focusing on the blood flow rate as much, because the flow rate might actually go up a little bit when you dilate the efferent arteriole, but the point is that the incoming arteriole has not enough blood flow to begin with. Okay, and basically you have very, very low filtration, and that's represented by one droplet. That's supposed to be a single droplet of fluid going through that's been filtered. Okay, so the point there is that, as even though we have, like I said, we have low pressure going in from the bottom, okay, from the afferent arteriole, this dilating the efferent, there's no reason why that would lower blood flow even more, right? It's not going to lower the flow, but it lowers the pressure in the glomerulus. And that basically is like if you have pinholes in a balloon and you don't really squeeze it, you're going to have very low water flow. Whereas if you squeeze it enough, you will get fluid flowing through. And then if you squeeze it too much, you might rupture it. rupture those holes, and that would be, basically long-term hypertension. So we want to be in the middle point there where we're filtering some fluid, but not too much and not too little. So what are the main consequences or manifestations of this? So if we have renal artery stenosis and we're dilating the efferent arteriole with a RAAS inhibitor, we have fluid overload in the plasma, we have accumulation of all things that are normally filtered. That would be electrolytes like potassium, phosphate, sodium. Creatinine is something that's it's coming from muscle breakdown. Creatinine would accumulate. That's why if you get your labs done, it'll say sometimes SCR. That's serum creatinine. If that's elevated, that's a sign of the kidney not functioning correctly. We don't want to jump to the conclusion that say there's a kidney damage, because it could be just low pressure in the glomerulus. Urea or blood urea nitrogen, BUN, would accumulate. Uremic toxins like indoxyl sulfate, basically metabolic waste from your metabolic processes throughout your body that's supposed to be eliminated either through the liver or the kidney. If your kidney's not filtering well, a lot of that will accumulate in the blood and cause changes in cognitive ability and many other things. And of course, drugs and their metabolites, many drugs depend on the kidney for elimination. So if you have, I guess a lot of people probably don't think about it this way, but so we normally think of if you give a RAAS inhibitor to someone with renal artery stenosis, you have poor filtration of your natural endogenous substances, but we also affect pretty much any drug that is renally filtered. So we have to always remember that if they're on other medications, these patients, then we have another possible issue with, drug toxicity. So the take-home points are that hypertension can damage the kidney and lead to protein in the urine. Okay, that's pretty simple concept. Too much pressure, too much opening of the pores. You're filtering larger things than you should be. Renal artery stenosis can be the cause of hypertension while also resulting in low glomerular pressure. So that's where you have, again, high systemic pressure, but poor filtration because of low glomerular pressure. Poor renal function does not always mean kidney damage has occurred. Okay, it could simply be low glomerular pressure. Okay, so to me, it's a very important concept to understand that you can't just look at someone's serum creatinine if it's elevating and say, oh, they must have, it could be glomerular sclerosis or scar tissue formation, but you can't just say it's kidney damage, right? It is kidney impairment, it's not working right, but it could be very temporary if it's drug induced, right? Especially a RAAS inhibitor induced. So RAAS inhibitors can protect the kidney in most cases of hypertension, but can worsen kidney function in renal artery stenosis. And again, that's the temporary worsening. As soon as you discontinue the drug, you should retain or regain that glomerular pressure back to whatever it was at baseline, and then retain whatever filtration ability you had. Okay, so if it already started off poor, then it'll go back to fairly poor, but essentially it should get better if you discontinue a RAAS inhibitor and someone has renal artery stenosis. In fact, like I said, it's contraindicated. So that means you can't give it. You can't give one of these drugs. However, if someone only had unilateral stenosis, or only one kidney had that issue, or one renal artery, then it's not contraindicated, unless you only have a single kidney, obviously, and that's obviously a special situation. So that wraps everything up. Hopefully this demystified ACE inhibitors and RAAS inhibitors in general, and whether or not they're renal protective or detrimental to the kidney. So it depends on the context. And thank you for listening, and have a great day. Thank you.